First, to consider the needs of people we serve first. Involve the people we serve in the planning process. Ask and listen to what people are saying about their needs. Advance the mission, vision, network values, which are to inspire hope, empower people, and strengthen community. And this is a Medicaid rate reduction. And so that we wanted to make sure that within that context, that the Medicaid principles, the Medicaid processes, we're focused in strengthening. Medical necessity, due process, the increased use of natural supports, etc. We needed to focus on Medicaid or administrative reductions, not service reductions. We need to strengthen Medicaid, services. Reduce cost variances within service groups across our network, and we needed to create a more, I put on there, a unified system. But one of the things that we have been struggling for and striving for and making a lot of headway is to be able, no matter where you are in our county, that you have a consistent set of services. And so we needed to make sure that we did not lose sight of that for the citizens that we serve. And we also wanted to make sure that we did not cut services in the dollars, in the encounters, into people disproportionately than what we did our administrative activities. So that's what we set out in October to be able to do.
We are looking at efficiencies. We are looking at cost variances, achieving these through some administrative reductions, changes in healthcare packages, efficiencies in technology. We do also continue to look at crisis management and wherever we can divert from psychiatric hospitalization. I think our rate here in this state is wonderful. We have a low percentage of people who are hospitalized. We have a quick turnaround. We have some pretty good discharge planning for people, but we do pay general fund dollars for those services, and so we want to make sure people's lives are supported as they move back to the community. We're looking at outcome purchasing, not doing things in the old way, but really purchasing, value purchasing, and what are our values, what are our principles, and what practices do we really want to occur. We're looking at partnerships and collaborations. I know there are some providers in the audience. I have challenged some providers, whether you're a direct provider or not, to say, how can you collaborate and coordinate? Can you share back office functions with information and technology, with training? And let me say we're also doing that across the metro region. We have partnerships with Macomb County Community Mental Health as well as Detroit Wayne. And so we're trying to figure out how we can create administrative efficiencies across the region. One of the examples is what is called reciprocity of training, meaning if direct staff are trained in Wayne County and a provider in their network says, gee, I would like you to now work with somebody in Oakland County, that the training that they had in Wayne County is recognized in Oakland County. That saves staff time, that saves training dollars, and so we already have that around recipient rights training. So we're definitely working that with our cohorts in the region. And then finally, accessing funding and other resources. We know that we continue to pay in some instances when Medicare should pay. We know that we may be doing some things that our federally qualified healthcare partners or through integrated healthcare could be accomplished and paid for in other systems. So we'll continue to do that. And the more we can bring money to the table and those kinds of resources, the less we really have to move into reductions. Nonetheless, the mantra continues to be taking a look at the cost per person and reduction of rate variances across the network.